Imagine going in for a routine medical procedure, something you assume is totally localized, like maybe an intervention for a highly specific area of your body.
Right.
And then the doctor tells you that a tiny invisible implant hidden anatomically miles away completely changes how they have to treat you.
It's wild because we really like to think of our bodies as these um, distinct, separate zones that can be managed independently.
Exactly. Like you fix the plumbing in the kitchen, it shouldn't change the wiring in the attic.
Yeah, it's a comforting thought, but human biology just doesn't respect compartmentalization.
Mm,
Every intervention echoes through the entire system.
right.
Treating one area in total isolation is essentially a myth, especially, when we start dealing with the endocrine system.
Well, welcome to today's deep dive. If you're listening to this and wondering why a clinic would even care about your arm when treating your pelvis, you definitely aren't alone.
Not at all.
Our mission today is to answer a highly specific, but honestly fascinating medical question. Can vaginal tightening be done while using the contraceptive implant?
And answering that requires mapping out a surprising amount of anatomy, endocrinology, and actually even physics.
Yeah, the physics part is wild. So to get to the bottom of this, we've pulled a pretty massive stack of sources.
We really have.
We're looking at official FDA drug labels, like the one for the Nexplanon implant. We've got clinical guidelines from the Faculty of Sexual and Reproductive Health Care, plus safety communications directly from the FDA, and some heavily detailed clinical FAQs from providers like the Women's Health Clinic and the Berman Brief.
Synthesizing all of these lets us move past the glossy marketing brochures you might see in a waiting room. We can actually look at the cellular reality of what happens when advanced technology meets human tissue.
Because figuring out if these two things are compatible, an arm implant and a vaginal energy device, means exploring the mechanics of subdermal hormones.
Right, and the physics of lasers and radiofrequency.
Yeah, and the crucial differences between having metal in your arm versus, metal in your pelvis.
It serves as a perfect case study in viewing the body as a holistic, interconnected landscape.
Okay, let's unpack this. Most people are familiar with the contraceptive implant.
Sure.
It's a tiny, flexible rod tucked subdermally in the inner arm. It is wildly effective. Basically the gold standard for preventing pregnancy, and it's progestin only.
Right. Absolutely zero estrogen.
It just sits up there in the arm, quietly releasing hormones. So if the implant is physically tucked away in a completely different postal code from the pelvis, why would a clinician treating the vaginal canal even ask about it?
That's the logical question, right?
Yeah, I mean, are patients just overthinking the paperwork, or is there a systemic mechanism at play here?
Oh, from a purely spatial and physical perspective, the implant is entirely a non-issue.
Okay.
It's made of non-biodegradable plastic, it contains no metal, and it's physically out of the treatment zone. A laser applied to the pelvic region isn't going to accidentally hit or, melt an implant up in the bicep.
That's a relief.
But the physical location is, it's a distraction from what the implant is actually doing.
Mhm.
Its biological reach is entirely systemic.
Because of the hormones.
Exactly. Those hormones travel through the bloodstream, altering the endometrium and changing the viscosity of cervical mucus.
Which means it's actively altering the baseline environment of the tissue the clinic is actually trying to treat.
Right. And understanding that baseline is the single most important factor for these procedures. Vaginal tightening treatments, they're often referred to as energy-based devices or EBDs, they rely entirely on the body's natural healing response.
Oh, I see.
The device creates a controlled microtrauma, a microscopic burn, basically, and the body has to rush in to heal it.
Which brings us to the hormonal environment. Hormones dictate the rules of engagement for how the body heals.
Absolutely. Estrogen is essentially the biological architect of vaginal tissue. It dictates the thickness of the epithelium, the blood flow, the hydration levels, and the natural elasticity.
All right.
Because the arm implant is progestin only and it suppresses ovulation, the patient's endogenous estrogen levels can fluctuate or become suppressed.
So it changes the architecture.
Yeah, progestin dominance can sometimes mimic a localized low estrogen state in the vaginal mucosa.
Which means the tissue might be thinner or more fragile or just less vascularized before the doctor even turns the machine on.
Exactly. The clinician isn't worried about the laser interacting with the implant. They are evaluating whether the vaginal tissue is currently robust enough to endure thermal trauma.
Ah,
They need to know it can respond by building healthy new collagen, rather than just sustaining damage it can't repair.
that makes total sense. If the tissue is already compromised by a shifting hormonal baseline, applying a high-heat laser could lead to disastrous scarring instead of rejuvenation.
Right, so the arm implant is a biochemical variable, not a physical hurdle.
But if the physical location isn't the problem for the arm implant, what happens when the contraceptive is sitting right in the line of fire?
Now that's a completely different scenario.
Yeah, that brings us to IUDs, or coils.
The transition from systemic hormones to localized physical devices completely shifts the risk profile. Now we're dealing strictly with the physics of the energy devices.
Because a lot of patients use the Paragard copper IUD, which sits directly inside the uterus.
Right.
If a patient is lying on the table for a vaginal tightening procedure, they have a piece of metal residing right at the top of the vaginal canal.
They do.
But the clinical FAQs from the Women's Health Clinic point out that an IUD does not automatically disqualify someone from laser or radio frequency treatments, which honestly initially sounds a bit counterintuitive.
It does sound weird, but it all comes down to the depth of penetration and the specific wavelength of the energy.
Okay.
Lasers used in these treatments, like the CO2 Mona Lisa touch, are highly calibrated. A carbon dioxide laser specifically targets the water molecules within the tissue.
Right?
It essentially vaporizes the moisture in the very surface layers, the mucosa, and the immediate submucosa.
So it's basically acting on just a fraction of a millimeter of tissue.
Exactly. It simply doesn't penetrate deeply enough to travel up the vaginal canal, cross the barrier of the cervix, and enter the uterus where the IUD is anchored.
Oh, wow.
Yeah, the energy dissipates long before it ever reaches the contraceptive device. The IUD remains completely isolated from the thermal effect of the laser.
Okay, but our source material from the Berman brief highlights a massive caveat to this.
Yes, a very important one.
That safety rule only applies to light and shallow radio waves. There is a totally different category of energy being used in these clinics, particularly a treatment called Emcella.
Right. Emcella discards the concept of a shallow, localized laser wand entirely.
It's totally different.
It's a non-invasive chair that the patient sits on, fully clothed.
Wait, a chair?
Yeah, a chair. It utilizes high-intensity focused electromagnetic technology, which is often abbreviated as HIFEM.
Oh, okay.
The goal isn't to burn the surface tissue to create collagen. The goal is to penetrate deep into the pelvic floor to force the muscles to contract.
It's generating a massive magnetic field that forces the pelvic floor into thousands of supermaximal contractions.
Basically, yeah.
It's like doing tens of thousands of Kegel exercises in the span of 30 minutes. And because it relies on a penetrating magnetic field, suddenly that copper IUD is a huge problem.
Oh, a massive problem. Magnetic fields don't stop at the surface mucosa. They sweep through the entire pelvic basin.
Right.
If a patient has a copper IUD or any kind of surgical metal plates in their pelvis, that magnetic energy interacts directly with the metal through a process called inductive heating.
You know, when I was reading the breakdown of this, the first thing I thought of was a baked potato in the microwave.
That's actually a great analogy.
Yeah, like if you accidentally leave a tiny scrap of aluminum foil on the skin of that potato and hit start, the microwaves interact with the metal. It sparks, it superheats, and it severely burns the potato from the inside out.
That is a highly accurate way to visualize inductive heating. The magnetic waves excite the electrons in the metal IUD.
Right.
The metal acts as a resistor, and that resistance generates profound heat. The patient is risking severe, localized internal burns directly inside their uterus.
Which is terrifying.
It really demonstrates why a patient simply cannot view vaginal rejuvenation as a single uniform category of treatment. A shallow CO2 laser and a deep penetrating electromagnetic chair are as fundamentally different as a flashlight and a microwave oven.
Here's where it gets really interesting, though.
Yeah.
We've established that these devices use wildly different mechanisms, and we know that clinics use them to induce a healing response. But when we look at the July 2018 FDA safety communication, the regulatory pushback is intense.
Extremely intense.
Former FDA Commissioner Scott Gottlieb issued a severe warning against marketing these energy-based devices for cosmetic tightening or vaginal rejuvenation.
Right, because the FDA's mandate is absolute population safety.
Sure.
They noted that while these lasers are legally cleared for general surgical functions, like cutting, destroying, or coagulating tissue in an operating room, they were never officially approved for treating the genitourinary syndrome of menopause or for elective cosmetic tightening.
Right, and the FDA cited reports of serious life-altering adverse events.
We did.
To understand why the FDA sounded the alarm, we have to look at the mechanism of failure.
Yes.
The detailed overviews from NICE, the National Institute for Health and Care Excellence, describe catastrophic outcomes. We're talking severe internal burns, the formation of crescent-shaped fibrous bands, and even vaginal canals foreshortened to just 2.5 centimeters.
It's devastating.
How does a device meant to stimulate a little extra collagen end up functionally fusing the tissue together?
It all comes back to the biology of a scar. When the device burns those microscopic columns into the tissue, it triggers the release of heat shock proteins.
Okay.
These act basically as biological distress beacons, calling in fibroblasts to lay down new collagen and elastin.
Right.
In a healthy, well-regulated healing environment, the body weaves a neat, organized lattice of type 3 collagen, which is flexible and elastic.
But if the tissue is compromised, like maybe the hormonal baseline is off or the thermal energy was just too high, the body panics.
Exactly. The healing cascade becomes chaotic. Instead of weaving a flexible lattice, the panicked tissue dumps thick, disorganized type I collagen.
So it's rigid.
Yes, this is rigid scar tissue. As that scar tissue matures, it contracts and shrinks. That contraction is what forms those crescent-shaped fibrous bands.
Wow.
It creates severe strictures, partial obstructions, and the foreshortening of the canal you mentioned earlier. It basically transforms functional elastic tissue into a rigid, painful blockade.
A patient goes in hoping to fix some laxity or dryness and ends up completely losing the ability to engage in penetrative intimacy without months of painful physical rehabilitation or even corrective surgery.
And those are the catastrophic endpoints that force the FDA to step in. They basically said the long-term safety data simply isn't there to justify using destructive thermal trauma for elective cosmetic outcomes.
Yet the clinical providers pushed back hard against the FDA.
They really did.
The Women's Health Wise Clinic published a direct response highlighting the actual statistics from their ground-level experience. They pointed out that out of over 100,000 procedures performed across their network, there were only 14 official reports of severe complications.
Right.
We are looking at a 0.014% complication rate.
What's fascinating here is the profound tension between the two perspectives. We are using destructive trauma to trick an aging body into regenerating itself.
Right.
And the FDA's core issue isn't necessarily that the technology fails to work, but that it works far too aggressively when it goes wrong.
Yeah.
But from the clinician's perspective, they are treating patients whose quality of life has been decimated by severe vaginal atrophy or painful intercourse.
And the standard alternative is localized estrogen cream. But many patients are breast cancer survivors who just cannot safely introduce hormones into their bodies.
Exactly. Or they find the creams totally ineffective. Even those localized creams carry FDA black box warnings for cardiovascular issues.
So patients find themselves trapped between debilitating daily symptoms and regulatory warnings.
Right. When traditional medicine offers no viable alternatives, a 0.014% risk of a catastrophic outcome becomes a highly rational gamble for a patient desperate to reclaim their physical comfort.
That dynamic makes the clinical triage process absolutely vital. If a patient is willing to take that gamble, the clinic has to act as the final safety net to ensure they don't fall into that 0.014% category.
They have to be incredibly careful.
Based on the Women's Health Clinic guidelines, this involves a really rigorous checklist that separates patients into green flags and red flags.
A reputable provider is looking for absolutely anything that destabilizes the baseline tissue. Pregnancy and the immediate 3-month postpartum period are absolute red flags.
Why is that?
Well, the pelvic floor is heavily vascularized then, flooded with shifting hormones, and actively navigating its own natural healing cascade.
Okay, that makes sense.
Adding thermal trauma to that environment is entirely unpredictable.
They also immediately rule out active pelvic infections. If a patient comes in with a UTI, an active herpes flare-up, or certain active strains of HPV, the procedure is canceled.
Absolutely.
Applying a laser to an active viral or bacterial infection is essentially like aggressively massaging a sprained ankle. You aren't healing the underlying problem, you are just massively accelerating the inflammation and spreading the microscopic damage further into the surrounding tissue.
That's exactly it. Severe structural prolapse is another disqualifier. A laser acts on the surface mucosa. It cannot repair the deep fascial tearing or muscle failure that causes pelvic organs to drop.
Right.
But the most revealing part of the triage guidelines involves unexplained pelvic pain or unexplained bleeding.
Wait, let's look at the arm implant again. We know from the FSRH guidelines that one of the most common, well-documented side effects of a progestin-only implant is unpredictable, erratic spotting.
Yes, very common.
If a patient comes in for a tightening procedure and they mention they've had some recent spotting, the clinic is going to hit the brakes. Aren't clinics just punishing patients for a completely normal side effect of their contraception by turning them away?
I mean, it definitely feels like bureaucratic gatekeeping to the patient. They know their implant causes spotting, so why is the clinic overreacting?
Exactly.
But the clinic has to assume the worst. Unexplained bleeding might be a harmless side effect of the Nexplanon implant, but it is also the primary warning sign of cervical cell changes or an undiagnosed malignancy.
And if a clinician fires a laser at a bleeding precancerous lesion,
They will cauterize it. The intense heat of the laser will seal the blood vessels on the surface, effectively stopping the symptom.
oh, wow.
The patient goes home thinking the treatment was a success, completely unaware that the clinician just masked a tumor.
That is terrifying.
By the time the bleeding returns or new symptoms appear, the cancer has progressed quietly for months. Elective tightening should never be allowed to obscure or temporarily hide the symptoms of a dangerous underlying pathology.
Right.
The baseline health of the tissue must be completely verified before adding any new variables.
So the triage checklist isn't there to frustrate the patient. It's there to prevent a cosmetic procedure from accidentally maiming them or hiding a life-threatening illness.
Exactly.
It really separates a true medical professional treating holistic health from a salesperson just trying to book a laser session.
The standard of care demands that the clinician fully understands the physiological environment they're stepping into.
So what does this all mean? We set out with a highly specific question. Can vaginal tightening be done while using the contraceptive implant?
Right.
For you, the listener, the direct answer is yes. Having a subdermal, progestin-only implant in your arm does not physically or chemically disqualify you from exploring vaginal laser or radiofrequency treatments.
But that yes requires a deep understanding of the context.
Definitely.
The specific wavelength of the energy, the presence of any concealed metal like an IUD when utilizing magnetic therapies, and a rigorous, uncompromising evaluation of your overall pelvic health. Those are the true variables that dictate safety.
And that is exactly why exploring the underlying mechanisms is so important. Knowledge is your primary defense.
Absolutely.
Whether you are actively researching these interventions for your own health, or you just have an insatiable curiosity about where medical technology is heading, understanding the how and the why protects you.
It does.
When you realize that medical aesthetics isn't just a casual spa treatment, but a highly complex collision of anatomy, endocrinology, and physics, you insulate yourself from being swept up in simplified marketing hype.
It equips you to enter a doctor's office not as a passive consumer, but as an informed participant. You aren't just asking what the machine does, you're asking how the specific modality of energy will interact with your unique hormonal baseline.
It elevates your entire approach to personal healthcare. Before we close out, there is one final thread buried in this research that we haven't resolved, something to mull over long after this deep dive ends.
Well, yeah.
We know the fundamental mechanism of these energy devices is forcing the body to rapidly produce new collagen to heal controlled microburns. That densely woven collagen creates the tightening effect. But what happens over time?
That's the million-dollar question. We only really have short-term data on the success of these treatments. The monumental unknown is how this artificially stimulated, densely packed scar collagen behaves a decade or more down the line.
Right?
As the patient continues to age, as their natural estrogen levels plummet during menopause, does that laser-induced collagen retain any of its flexibility?
Or does that previously traumatized, heat-treated tissue become increasingly rigid, brittle, and unyielding over the next 15 years?
It's a scary thought.
Does a quick fix today inadvertently set the stage for severe tissue dysfunction and aggressive surgical intervention in the future?
We simply do not have the longitudinal data to answer that yet. We are witnessing the very first generation of patients move through the long-term aftermath of these specific aesthetic devices.
It brings us full circle. A localized fix today becomes the permanent baseline architecture of your body tomorrow.
Right.
Biology doesn't forget trauma, even when it's therapeutic. Every choice echoes through the entire system. Keep that in mind the next time a brochure promises a quick, isolated solution. Thanks for diving deep with us today.